question answered. Anybody have any questions?
One of them works just that. Okay, so this question is for all of the doctors. For some of us, we have been dealing with this longer than others. And for example, at first up, they're just arriving, and in Act 2 land. And so the question is, if you have a procedure that, you know, it's a lot of information to take in with anesthesia and complex care, and then we have urgent care. If your child's going to go in for a procedure and you need to prepare them, and you have a new primary care physician or pediatrician that is not familiar with Act 2, it's like, what's the bat phone line? Like, who do you call? What do these parents do to coordinate on anesthesia? Like, you know, do they give a white paper to the anesthesiologist? Like, how do they procedure that they need to do? How do we direct them?
So I think at most like larger hospitals that these kids would probably come in for a preoperative evaluation. And if they had further questions, usually they would consult the specialist taking care. They're certainly more than welcome to show them the paper that we wrote, and it has our contact information. I believe it has our contact, at least it has my contact information on it. And I'm more than willing to give, you know, whatever advice I can give, or certainly the team here that have taken care of a lot of these kids as well.
And I'll add that for individuals who've just come to the surface over the last couple of years, often come to the attention of these symposia or these organizations. And so Dixie or Warren will reach out to us, and we'll often coordinate. We're happy to do that. We'll often coordinate like a quick pre-huddle with those individuals. So we've had calls or Zooms with an anesthesiologist in Germany who's facing this challenge, and we'll talk about our experiences, et cetera. There's no package though, except for the paper that Dr. Houska has created, I think, which is very powerful. But we're open to powwowing, if you will. Probably can't say it anymore. Having a meeting with individuals from wherever, which we've done a few times actually, and so that there's a quick or sort of in service, like this is what we've anticipated, but it's the individuals who are going to provide anesthesiology or anesthesia. They would have to be open to that. But some people have reached out and we've made connections. And I think that's part of how this community should grow. Any community that's supporting children with something so rare and challenging, so we should feel free to ask that question. And we support that effort.
The only other thing I would mention is, you know, if there was some sort of emergency or urgent situation where they could not get a hold of us, I would take care of any of these, and how I would say this is to take care of this kid as if they had moya disease. And that will usually accomplish the vast majority of the anesthetic goals for this child.
Amazing, amazing advice. As a parent, like, oh, kids with this condition have 40% of blood pressure drop and like whatever, they're gonna look at you with like weird eyes, like you're on drugs. But if you say approach this as a moya disease, immediately sets people up with high risk of stroke, and it applies to the brain, applies to the whole body, the low blood pressure, hypoperfusion. We are gonna we Diana Tambala, she's here. She's a research coordinator, but she's also a physician. She's a medical doctor, and she took the lead of grabbing all the recommendations that we have from the 2019 consensus here, plus everything that we've been learning together with multiple teams. And we are going to try to do the best that you can do in the medical care, because I'm pretty aware of the growth of this community is exponential. Okay. You guys are moving, you're getting people to get diagnosed and earlier and earlier. So we're not going to be able to do all these meetings on time very soon. And I want to be realistic, and it's not also the way that we want people to be taken care of across the world. Just remember, we speak English. A lot of people don't. And a lot of clinicians even can read English, but cannot keep a conversation in English. Okay. So we need to make sure that we publish. So all doctors, anywhere they are, have a guidance on how to think through it. So that's why his paper is critical. It's the first time ever that someone gave it a thought and systematically show this is what you can do. So refer them to his paper, his medical authority. He got it vetted by his peer reviews. That's what a paper means. And we're going to try to put something in writing, published for clinical guidance on anesthesia and critical care for MSMDS. And we need all your doctors to do a consensus. Okay, we'll work with a small group to put forward the questions that are critical, and then try to get a sense. And so far, from most of you, we've been having very collaborative physicians. Like I would have to say, the most difficult part is time. Like these guys don't necessarily have time to, like, time zones and stuff, like sit down for another hour to learn for a patient. I wanted to say to Dr. Schnell, if you get a Dr. Schnell and you can have your hospital do this, that's the way to go. That's how I wish everybody has the real steward with you in your hospital system. So there is someone else interacting and preparing and suggesting amazing ideas. Like, wait, by the way, it's not going to push the tube out, you know? It doesn't move that way. Like, and mom can say that, and they may look at her like she's on drugs. But a physician says it, and then there is a different entrance of information. I want to put another note here. I have a lot of my kiddos with pediatric stroke, with brain injury that I neglect every day because I take so many hours to take care of these kids. So when you're demanding, we're taking from someone else. We're not that many, guys. There's very few people with expertise in the different areas. Even cardiac anesthesiologists in pediatric are not that common. So be merciful, if I can ask something, when you interact with physicians and the residents and the trainees. These guys are on edge, okay? Edge not because they have an attitude and an ego. They need to get a lot of things done in an hour, in the next hour, in the next 20 hours, for other people to also be safe and okay and taken care of. So I just put that note there because we're creating a sense that you should have a Dr. Schnell and a Dr. Carroll and a Dr. Houska and a Dr. Mussolina and Lindsay. Yes and no. We need to make sure that we can standardize medicine and share the conceptual knowledge. He just told you what to say. Moya. We give people things that they understand a little bit more. Done. They're clinicians. They can think. Nurses, technicians, anyone taking care of the therapist. This is very helpful for the therapist. To know blood pressures goes down is very helpful to the physical therapist. To know how you're going to be working, what position you may want to put the kid on, etc. So I think it's a lot of work on us to put it out and on you guys to communicate it across the community, new diagnosed families, and to get us your teams to help us consent, because there is no evidence-based medicine. We're going to be doing this out of our best understanding of physiology and how it works. And we're not going to be able to generalize like cookie cut prescriptions. We're going to put concepts that people can then use to think through the cases. but more work coming your way for sure.
All right, we have a question online. Angela asked, to avoid general anesthesia, could an epidural be an alternative if the child needs a small operation, such as a knee operation, or are there other risks with an epidural?
So certainly, there are, just a few limitations to that. One is if the child is on any blood thinners. Two, an epidural can also drop your blood pressure. Probably maybe as much as general anesthesia, but it may matter on what the other comorbidities are. If we're more worried about respiratory or pulmonary and the risks of intubation or things like that, an epidural would be a great choice for procedures. One thing I often advocate for, even if epidural can't be used as the anesthetic, for a lot of procedures, it is a very good tool to use for analgesia afterwards to avoid having to give medications like opioids and things like that that have a lot more side effects.
Questions?